Hi, welcome to our podcast. I'm Dr. Nelson Moses, an SLC and retired professor who has taught at several university programs in speech language clinical services and a founder of the graduate SLC program at Long Island University, Brooklyn campus. Today, my colleague Kimberly Osam will speak about her experiences over the past several weeks and beyond involving her son's hospitalization for complications related to dysphagia, which is a swallowing problem her son has experienced throughout his young life. Kimberly, who is both a mom and SLC, has worked in hospital settings. She raises in today's podcast issues she and her son have experienced finding appropriate assessment and treatment for her son's dysphagia issues. We have posted on our YouTube channel, Moses Osam Languaging, a presentation Kim and I did at the American Speech Language Hearing National Conference last year. That presentation will give you some background for today's podcast. As you listen to Kim's presentation on dysphagia and treatment, keep your ears open to a subtext of Kim's story. It's about languaging, which is the central focus of this podcast series, and a book we're working on for the Taylor Francis Routledge Publishing imprint. Our book is about reimagining clinical assessment and treatment with reference to languaging and the presumption of competence of everyone who comes to us for service. The term languaging refers to the process each of us possesses for representing, that is, coding in real time, our content of mind, our ideas and emotions and intents that are passing through our mind in real-time streams of consciousness. The subtext of Kim's presentation about her son's dysphagia experience is this: her son's languaging and efforts at communicating his discomfort and downright pain and fear associated with his dysphagia experiences were ignored, which is often the case with children and adults with perceived disabilities, including autism, stroke, etc. Folks who have not presumed competence in these individuals, who have ignored or attempted to extinguish the non-standard ways of languaging some individuals with perceived disabilities employ, has placed Kim's son and others who have had the same experiences in real danger and have extended their serious personal discomfort and fear and everything associated with the experience of dysphagia. Okay, so hi everybody. I'm Nelson Moses.
Hello, and I'm Kimberly Osam. Welcome back, everyone.
Kimberly, it's all yours here. Kimberly's got a story to tell. Kimberly, tell her.
Well, I just wanted to take everyone back a little bit to our ASHA presentation that we did in 2025 for the centennial. And it was about agency and an autistic child. And I'm coming to you guys with a little bit of a different background behind me. That's because I'm currently back inpatient at the Children's Hospital with my son. And the reason I wanted to refer back to our presentation was just that, just to speak to caregivers and clinicians about how you can advocate for, any individual who you're treating in an acute care setting. Doesn't have to be someone autistic like my son, but I use him as an example because I feel like sometimes these experiences that I have, just seeing things from both lenses, from the clinician lens and then from the mom lens, I think that it informs assessment and treatment, and also approach when you're speaking with your clients, just so that we can make sure that they do have the best outcomes. Why is all that important? Well, fast forward to this is actually our fifth admission. I didn't misspeak that as in one, two, three, four, five, since June the 5th. And this is being recorded on 4th of July. So I'm happy 4th of July, everyone. And why was my son admitted? Well, difficulty swallowing. How ironic. My son has had dysphagia for many, many years, and he's been a feeding clinic patient for coming up on a decade. But recently he had a downturn. He had what I believe to be an aspiration event when he was eating, and shortly after that, consumed less and less food. He was coughing, gagging, kind of regurgitating on both liquids and solids that he had been doing very well on for the past several months, so much so that he was getting ready to graduate from the feeding clinic at the beginning of August coming up. After this pretty acute downturn, he ended up losing about 15 pounds just in a matter of 2.5, 3 weeks. And it continued just with the gagging, got very dehydrated and ended up being taken to the hospital and admitted. Well, mom being an SLP, I didn't think I needed to say that or let anybody know that. I just thought that, okay, we're going to get the standard of care no matter who you are, which is, of course, what we all expect. And so when I came in and I'm thinking, okay, swallowing difficulty that onset very acutely, we have signs. My son was using his AAC device to advise of symptoms. We have weight loss. We have just a whole gamut of things that we can demonstrate that it's indicated to do an instrumental assessment. So we admitted, and I found out pretty quickly that that was not the plan. I found out that I was being pushed toward outpatient. And so I said, okay, well, let's see, maybe outpatient will be pretty quick, but I made it clear that I wanted a swallow study as soon as possible because otherwise my son was going to have an alternate means of nutrition hydration. And so during this first admission, again, I really thought that we would get the swallow study, but we did not. And so fast forward, we had another admission. And the same thing for swallowing, increasing difficulties with swallowing, signs and symptoms worsening. Um, Requested again for the swallow study, told it would be outpatient. Third admission, the same thing. Fourth admission, the same thing. And as I said, I'm coming to you live from the fifth admission. And I was just informed that there is a possibility that we might get a swallow study before we leave. And the thing that I found interesting was the other disciplines that I spoke to, and even the folks who would come and take my son's tray were like, why hasn't he had a swallow study? We see how his food is kind of regurgitated on the tray. We see, we hear him, coughing on what he's trying to eat when we bring it, to him when we are coming back and he's still eating. And to be honest, I could not answer that question. The nurses were asking me. It seemed like everyone but my own discipline was asking me that. Fortunately, on this fifth admission, there was a different SLP who came in, and she agreed that the outpatient date that we had been given for the swallow study for someone who has had an acute downturn in swallowing with active signs and symptoms of that date being out in August was not ideal. And so I just wanted to pose the question to you guys. I spoke with several different clinicians here across disciplines, including our own, and I was asking them, am I asking for too much? And I kind of made the example to them that it would be one thing if my son was here for a broken leg and I was insisting on a swallow study. And I said, well, my son broke his leg and I just want him to have a swallow study while he's here. I could see them coming back and saying, well, that doesn't seem to be related that we can find to why he's here. So why don't you wait for outpatient and we have a spot in a couple of months? But to have 5 admissions for swallowing difficulty, um, I just didn't feel like that was asking too much. So I was kind of joking with myself because, again, when you're a special needs parent and clinician, sometimes you have to do that. And I kind of joked and I said, wow, I think I found something that's kind of more elusive than Bigfoot and unicorns, and that's to get an actual instrumental assessment in an acute care facility when you actually have signs and symptoms. And so the reason I say that is not to question anyone's clinical judgment. Um, it wasn't as if I would have said that if it was a matter of just radiology not being available on those 5 different admissions. But I really just wanted to pose the question, could it be that sometimes within our profession, um, we feel that either we can't advocate for a patient who we believe might need a swallow study, an instrumental assessment. Maybe that was the case. And I would say that I would encourage all of us in our profession who deal with swallowing that I believe that that is actually our calling. Um, we're the ones writing the notes. We're the ones writing up the assessments, and we need uh, data to put in that objective section. Excuse me. We need data to put in that objective section of what we're writing, and mainly what was done was stuff that would kind of be in the subjective section of what would be written. But to be able to say, I mean, I just found myself doing things as a clinician that I knew needed to be done, even though I wasn't told to do them. I was weighing his food before and after to try and figure out what he was uh, taking down. I was looking at, the different sizes of what I was presenting him, how I was presenting him, his positioning. I found a stethoscope in the room and I took it and I was kind of just listening, over here, just kind of for residue, at the pharynx and stuff like that. I was checking his vitals as I could, counting the pulse, before and after to see if I had changes, just all the things that I thought would have been done when I was offered a bedside swallow instead of an actual instrumental assessment. And I was thinking to myself, wow, so what if I wasn't an SLP? What if I wasn't an SLP? What if I didn't know that those signs and symptoms were something that can be cause for concern? Not always, but can be cause for concern. And I know that for patient outcomes and for patient safety, I need to at least rule them out. I need to do a differential diagnosis. Um, Maybe it could be reflux. Maybe it could be something else. Maybe he could be having some penetration, but it's not aspirating. Maybe he could be aspirating, but then expelling it with his cough. But at that time, his cough was pretty weak. But here's the thing. All of those things are supposition until I have an actual instrumental assessment to see them. That's what I would need to be able to definitively say that this child, and I'm in a pediatric setting here, this child who is on his 5th time back with the admission for decline and difficulty in swallowing, what we would call dysphagia, has not had an instrumental assessment. And so, again, I don't say that to cause division in our profession. I just say that to say that sometimes, if it's kind of in the back of your mind, hey, maybe I'm getting a little pushback from here or there. If from what we have studied when we were learning to become SLPs, that these are the signs and the symptoms where it is indicated that we should, as a best practice, do an instrumental assessment so that we don't do further harm to the patient, then we need to really advocate for that. And I know that can be difficult in a big hospital setting. As I shared before in previous podcasts, I still work PRN at a rehabilitation hospital. I did part of my clinical fellowship there. I've been at the hospital for 10 years now. I worked there even before I was an SLP when I was going to school. And I know that in hospital settings, especially in acute, There could be pressures coming from all kinds of different directions. As I mentioned before, it could be radiology, it could be coming from, a sister discipline. But it's our job to the patients who've entrusted us with their care on our caseload to be the one that says, hey, you know what? I really feel that it's going to be best that we rule this out. Because the way I'm thinking about it now, say we don't get this swallow study on its fifth admission, say we do wait until August, and say in August we find that my son's been aspirating all that time. Now, what do we do? Have we done the patient further harm? Are we creating more of an aversion? Because that's what seemed to me to be happening. The more that he's having difficulty with swallowing, the less he's willing to try to swallow. And then we have the sensory part on top of that from him being autistic. So I just wanted to pose that, and I just wanted to kick it over to Dr. Moses for a minute, who's been kind of with me on this journey because every time we've been trying to meet, I'm like, oh, I'm back at the hospital, and it almost seems like I'm making it up. To have five different hospital admissions for the same thing um, within, wow, a month, within, wow, less than a month, within less than 1 month. And that doesn't include the ER visits that were in between those, all for swallowing difficulty. So, Dr. Moses, what do you have to say about my little soapbox that I was on there?
Do you have any advice for parents, a non-SLP, from the point of view of advocating for or under what conditions they need to advocate for their loved one who's having potential swallowing issues, feeding issues, dehydration, or other severe weight loss, etc.? How can a non-professional advocate? Any advice there?
I would say in my case, what happened was be persistent. Again, I wasn't upset. I wasn't disrespectful to anyone. I was just persistent. Every time someone would come into the room, no matter what discipline they were from, I would say, I just don't understand why my son is having a very acute change over a short period of time in his swallowing to the point where he's basically in failure to thrive right now, where we're having to do supplemental nutrition for him. And we haven't done a swallow study to see if we can improve the swallow or find out if there's something that we can do to avoid doing something more invasive. Um, well, why is that important? Because with my son's autism, the first thing that we had to do, because we couldn't get a swallow study to try and figure out, hey, is there something simple that maybe we could fix, like maybe give him some reflux medicine or something like that, if he's coughing on the reflux, is they put in an NG tube and they put him out to do that. Well, when he woke up with that tube through his nose and down his throat, guess what happened? There was a fight. There was a pretty gigantic fight, and it took many clinicians and resources and additional chemical restraints. And we eventually ended up having to put some padded gloves on his hands to keep him from yanking it out. And it was in with the bridle that was supposed to keep him from pulling it out. And that didn't sit well with me either because my son, as I mentioned before, and we did mention in the ASHA 2025 presentation that we did, my son is an AAC user. He uses augmentative and alternative communication. And so they put these padded gloves on my son that had the Velcro strap on them, and they were pretty much like just big puffs so that you could not move your digits, move your fingers to try and rip anything out, just kind of like you had two pads on your hands. And that just didn't sit well either because as I mentioned in previous recordings and in the ASHA 2025 presentation, my son is an AAC user, so he could not communicate then. He could not activate his device. And the sign that he uses one ASL sign, he couldn't do that successfully either. So I finally had to say, okay, guys, he's going to have to be able to communicate with us. And so we were having to use by order of the doctor, a chemical restraint to kind of calm him down and then take the gloves off to let him be able to communicate with us. Long story short, they discharge us after putting the NG tube in. Um, we get 5 minutes from the hospital. I hear coughing, choking, gagging as I'm merging onto the interstate. I look over and the tube is hanging by the bridle from each side of my son's nose. I immediately turn back, go back to the ER, and they do cut the NG tube free from the bridle, but they leave the bridle in because the thought was that maybe if the bridle is still in, they can put another tube. And I kept telling them with my son's autism and sensory difficulties, I think that it's really hard for him to tolerate. This is what he's trying to let us know. And if the bridle isn't taken out, I'm worried that he's going to try to mess with it. And I actually, I don't think they meant for me to hear it, but I heard someone out in the hall saying, um, he'll stop pulling it fast enough. Just kind of a snide remark because it put in there so that it's a little bit painful if you try to pull on it to get it out to kind of deter kids from pulling on it.
Oh,
So they admitted us and we went up to the floor. And guess what happened? Not too long after we got up to that floor, I was getting this stuff settled and I turned around and the bridle was on the bed and my son had blood in his mouth. Um, and I got the nurse, she came in and checked him out. But I kind of had to make the statement that we really need to be careful to underestimate when someone with autism has an overwhelm of their sensory systems, because in that moment, whatever that NG tube was causing him to feel, whatever that bridle was causing him to feel, it was enough that he wanted it out, regardless of the damage that he might have done to his face, pulling that bridle out. So
I,
that wasn't an option.
and I did want to say it's not just people with autism. I had surgery several years ago. And the dog barking on this computer. Can you hear dog
No,
barking
I
behind
can't
me?
hear it.
Oh, good. There's
Mm-mm.
a dog barking here, but just I was telling about my experience as a patient with a ventilator down my throat when I woke up from anesthesia after a surgery, and I had to get it. I felt like I was choking to death on it. I'm very sensitive to stuff in my mouth as well, and I was trying to talk to tell them out, out. But first of all, you can't talk with a ventilator down your throat. So then I said, you know, I'm going to sign. I'm going to sign. And I signed, get it out now, out now. I can sign, et cetera, et cetera. Out. I know what I'm talking about, et cetera. I'm talking here. This is the best I can do. And that I had my hands to make the point. They didn't want to take it out. I literally felt it's a horrible feeling. I had to get it out. They finally took it out. But just to say, it's not just people with autism. It's you got to, again, from the
Yeah.
point of view of a patient in a situation like that, you have to be listened to. Your son needed to communicate.
Yeah. He needed us to listen to that communication that he was
And,
giving us. He
and
pulled it
be
out to let us
yeah,
know something.
and people could look at the pulling of it out and say it's non-compliance, he doesn't listen, and all the negative
Mhm.
crap they throw at
And that's what
kids
happened.
and blah blah
Yeah,
blah,
that's what happened.
as opposed to take this person's perspective. And again, I speak from my own personal perspective. It's a horrible feeling.
Or or just do a swallow study to see if
Or do
something
it,
else
yeah, the
can
proper
be
study.
done so that it's less
Not funny.
invasive.
Yeah.
And then we went from there to a what we thought was going to be a G tube, but they ended up having to put in a peg tube. And for
Mm.
those who don't know, there's certain types of tubes that you can have that are low profile, like buttons, things like that, that were more ideal for my son. He had had one previously that was placed several years ago, and the extension that you would use to put things through that, it doesn't stay on. And so it's less for the child to kind of have to feel sensory wise, and also less leverage if they're going to try to pull it. Whereas the peg tube has the tail, an extension that kind of just stays on it with the accesses to it. And so it's a lot of leverage if it's irritating you to just grab it and pull it. And so with that too, that's what happened. And it actually happened right after his initial surgery, which led to an emergency surgery, then another admission. Um, and which, of course, I asked again, can we get the swallow study? And long story short, that's why we're back here right now, broadcasting from the hospital, is because he did indeed pull it for a third time out. And because it was newly placed, it's just not safe for him to continue to do that. Many different reasons for that. And of course, stomach contents could kind of spill over into the abdominal cavity and make him, really sick, septic, or something like that, among other things. Um, so we're here trying to find answers. And this time, again, my advice to the caregivers, the parents out there, the significant others of someone who might have differences, sensory differences, whether they're young, whether they're geriatric, no matter who they are, and you need to support them in advocating for themselves. I just kept asking. And this time, when I came to, when the doctors came into the room to kind of give me the talking to about, this can't happen. Well, obviously, I know this can't happen. Nobody is sitting here and just letting a child do something that can harm themselves. um, I know this can't happen, but I guess what I want to ask you is, how come a swallow study can't happen? So it's like, can we find some middle ground here, that maybe if we could just probe? That's all I'm asking. That's all I'm asking. If we could just probe into the difficulties that we're actually observing. The symptoms, yeah, maybe that's something that he's communicating on his device. Maybe he's not being believed, but the actual signs that we're seeing when he's eating, the food that's being hacked up, coughed up, regurgitated up, the coughing, the throat clearing, the change in his breathing. When he does that, him immediately ceasing to eat once he has that event. Um, how can we probe that so that we might know if there's another way forward that might be more sensory friendly? And there may not be one. There may not be one. But I guess the question that I was really posing to them is, how would we know if we don't do the study? That's all that we're asking. When we're in school, we're trained and we're taught about differential diagnoses, all the different things that we can do, all the instrumental assessments that are available to us for our, objective data and stuff like that. But I just feel like if we haven't used the things that are available to us in our toolbox to make that differential diagnosis, and we do go to something more invasive, and we have results like this on certain populations, have we really done them a service? We're creating more kind of anxiety around medical procedures and things like that. And again, I'm not knocking any of the professionals who've treated my son. I actually spent most of the day today writing up the award notices for several of the staff members who have helped him. And every time we come back, so many of them are like, "Hey, you're back," and these types of things. Even down to the dietary staff coming into the room and saying, "Oh, we saw the last name pop up again," and so we entered all of his, meals in because we know what he eats from previous ones. I mean, wonderful people. I just feel, as I said earlier, sometimes in certain settings, we're under different kinds of pressure. And in that moment, that's when we need to think as a clinician, even though I might be getting pressure from this department or that department, what is indicated for my patient based on what I'm observing? What would help my patient to have a better outcome? What would be, if we want to look at it from kind of a financial standpoint, what would be more cost effective for the family or for the facility, for the insurance company? If you're that type of person who wants to look at it from a numbers or a standpoint of, well, those resources could have been used for something else. If maybe we could have done a swallow study on the first visit, and who knows, maybe we could have found something and said, hey, let's try X, Y, and Z, and then he ups his oral intake, and then maybe there's no need for G tube right now or NG tube or those types of things. But here's the thing. I can sit here and say that and say that and say that, but we didn't do that, so we don't know. And if we did that, hey, maybe it would have worked, maybe it would have not. But even if it would not have worked, at least we can document that we did everything that we could do to lessen the patient's suffering through an event that, as I was witnessing my son go through, was not very pleasant. Was not very pleasant. And at this point, he's still losing weight, but we're going to figure it out. But I just want to encourage all of you that, again, you have a lot of training, and you have a lot of good clinical understanding from the patients that you've treated, the experiences that you've had across different settings. Let those things speak to you. Hey, I've seen this before. Let me rule this out. Because here's the danger: if we don't rule it out, and then a later instrumental assessment shows that it was something, God forbid, that was maybe something like a cancerous growth that was causing the change in the swallowing. And now we've told the patient that they're going to wait to outpatient several months. And then maybe the oncology or the surgeon or somebody comes to you and says, wow, if we had known about this a few months ago, maybe it wouldn't have spread here or there. Again, I don't want to be the person for doom and gloom, but I think that we all learned that when we were in school, that it's going to be clinically indicated for us to do that, whether we send someone who has a voice issue or a swallowing issue to an ENT to rule out certain things that could be worst case, whether we refer them to GI to rule out something that could be worst case. Because I'm telling you, I really wouldn't want that on my conscience, that I deferred something based on a bedside swallow study when I had actual signs and symptoms repeated over several admissions, and I delayed. And then when someone finally did get an assessment that, God forbid, it came back as something like a cancer that these surgeons or another discipline would have needed a 2 to 3 month lead on, that we would have had we acted when our instincts told us. So really, again, I really don't want this to come across as I'm kind of dooming and glooming anybody. What I want this to come across as is that we have that power to advocate for our patients, whether we're the clinician, whether we're the parent, the caregiver, the guardian, the significant other. If we speak up, and again, not in a disrespectful way, not in a rude way, but just in kind of an interrogative type of way, asking questions. Again, I just don't understand why we're not doing the swallow study right now. Could you explain that to me? I'm seeing this, I'm seeing that. Why aren't we doing it right now? And then wait for that answer, because sometimes just asking the question, even if we don't have the answer, because again, most of us as caregivers, we may not be the SLP, we may not be the nurse, we may not be the GI or the doctor, but who we are is someone who is an expert in our loved one. And we owe that to them to ask those questions, even if it might feel uncomfortable, and to ask them over and over again if we're still seeing what we're seeing and we're not getting any answers. So again, praying for a happy outcome and a positive outcome for my son. I'm thankful for everything that anyone who's ever worked with my son has done for him. But I think that this can be a learning point for all of us, that, again, do no further harm. Rule things out when you can. That's what we're called to do, is the differential diagnosis. Because if it's nothing, then yay, we've done the patient a service because we did the testing. We have it documented that, hey, we did it and it was nothing. If we do the testing and it's something, yay, because we did the test, we now know the way to move forward. And I think that's a learning lesson that I didn't want to have to learn this way, but I'm glad that I learned it, and I hope it does help someone else.
Yes, well, thanks a lot, Kimberly. Thanks. I thought this was really an important thing to talk about and share. And thanks everybody for joining us here. Kimberly,
Thank
good
you.
luck.